really think all patients with myelofibrosis should be treated on a clinical trial. While we have really good JAK inhibitors that have been approved for single use, the response rates are really measured on those trials in terms of improvement in symptom burden and spleen volume. And and across the board, all of these JAK inhibitors are not uniformly effective. For example, spleen size response for most JAK inhibitors is somewhere around 30 to 40% of patients. And none of the JAK inhibitors actually alter the natural history of myelofibrosis. So I typically recommend that all patients be considered for a clinical trial and be referred to a tertiary center where there may be trials available. There's really been an exciting time in MF probably over the past few years because we have so many more options. And these options are really combining JAK inhibitors with other agents. And they're looking to hopefully, by combining with other targeted agents, either improve upon important outcomes such as cytopenias, but also hopefully target the underlying biology of disease. Here at my institution, we have several studies that are open, including the Cartos therapy, Cartos Pharmaceuticals naftamadilin study. I think that's a really interesting, exciting study because it's really using or enhancing the TP53 activity of stem cell of myelofibrosis cells, and more importantly, I think it's going to have broad accessibility as it's opening even in the community. So I'm looking forward to seeing all patients being treated on a clinical trial. I think there's probably two areas that are in really need of improvement. The only curative treatment we have for MF is a bone marrow transplant. Unfortunately, many patients with myelofibrosis, because of its long indolent course and the nature of the disease being more prevalent in older individuals who may have additional comorbidities, not all patients with MF are eligible for transplantation. And many high-risk patients may not be eligible for transplantation. And so our current therapies, while they are very effective at controlling the symptoms of disease, they don't necessarily account for a change in the natural history of the disease. So I do think that there's a lot of room for improvement in therapeutics that can maybe alter how long patients survive with myelofibrosis. We know JAK inhibitors improve survival by improving morbidity, but eventually first-line JAK inhibitors all do fail, and second-line treatments with myelofibrosis have much less efficacy from what has approved. So after failing one JAK inhibitor, another JAK inhibitor is not necessarily expected to be effective. So we're really lacking therapies for patients who cannot get to a transplant and may need more than one line of treatment. I think the other big area of improvement is how to deal with patients who have myelofibrosis-induced cytopenias. It's not uncommon for patients to present with anemia or thrombocytopenia, and many JAK inhibitors, including ruxolitinib, they have significant myelosuppression and dose-limiting, and that is really their dose-limiting toxicity. And we know that receiving adequate doses of the JAK inhibitor is important for improving splenomegaly, improving spleen size, improving morbidity, and hopefully from that aspect, improving survival. But not all patients are able to achieve that. And up until recently, we really didn't have any JAK inhibitors that addressed, that resulted in improvements in cytopenias. Recently, pacritinib and momelotinib were approved. Momelotinib has been proven to improve anemia or at least stabilize anemia in patients with myelofibrosis through ACVR1 inhibition. And pacritinib has been shown to prevent worsening thrombocytopenia and may also have some effect on anemia. So that's been helpful. But I still think we really lack treatments that help with improvements in long-term cytopenia.